This backbone, the Cladribine plus low-dose cytarabine alternating with a hypomethylating agent, in this case, 5-Azacitidine, was initially put together about several years ago without the Venetoclax. And what we found in an older patient population, where we were looking for new options of lower intensity therapy beyond just single agent hypomethylating agents, was that the combination of Cladribine and low-dose cytarabine alternating with a hypomethylating agent produced very high response rates in the range at that time, and complete remission and CRI rate of 65%. And a median overall survival of 14.8 months. And at the time, this was in comparison to single-agent hypomethylating agents, where we were getting response rates in the range of 25 to 30%, with a median overall survival anywhere from 8 to 10 months. And so this was, to us, an excellent backbone, well-tolerated, low early mortality. And so, as you all know, the discovery of Venetoclax and its activity in combination with low-intensity therapy in AML has sort of revolutionized the field in the treatment of older and unfit patients with acute myeloid leukemia. And so we know that with HMA and Venetoclax, we're seeing, again, CR/CRI rates in the range of 65%, with median overall survival in the range of 15 to 17 months. And so based on that, and based on our prior experience with Cladribine and low-dose cytarabine, the hypothesis was that the addition of Venetoclax to that previously very effective backbone could potentially even lead to higher response rates, deeper responses, and longer-term survival with potentially a higher cure rate. And so that was the genesis of the protocol, where we added Venetoclax to this backbone that we had previously found to be safe and effective. And that's how we came about with this protocol. And so we are presenting at the ASH meeting is our initial experience with the first 50-odd patients. And the median age there was 68 years of age, with about, I would say, 40% of patients over the age of 70. So it's exactly the type of population that you would expect in the older and frontline patient population. We knew that about 40% of them had ELN adverse risk, and about 40% had intermediate risk by the ELN criteria. And among those patients, among 55 patients, we found that the complete remission rate was 78%, with an overall response rate that's CR plus CRI only of 93%. And what was incredibly striking about this was that the level of MRD, or minimal residual disease negativity by flow cytometry, was 93% in patients who had achieved a complete remission, and about 84% overall. So very, very deep remissions in frontline treatment with Cladribine, low-dose cytarabine, and Venetoclax in this patient population. Coupled with that, the 4 and 8 week mortality were 2% and 4% respectively. So again, also fairly impressive in terms of tolerability in this patient population. So with a median follow-up of over 14 months, the median overall survival was not reached in the population, and the relapse-free survival was also not reached. And that correlated with an estimated 1-year survival of 70% in this population, and a median a one-year relapse-free survival of 66%. So again, a well-tolerated regimen, highly effective with deep remissions, durable remissions, which actually translated into a survival benefit in this population. In terms of toxicity, we did see myelosuppression universally in everyone, but the time to count recovery was not long, at least in the first couple of cycles, that was as what would be expected with the addition of Venetoclax to chemotherapy. And so the time to ANC, the median time to ANC of 1,000 during cycle 1 was about 25 days. Time to platelet count greater than 100 was 23 days during cycle 1. During cycle 2, the median time to count recovery of ANC greater than 500 was 21 days, and platelets greater than 50 was 23 days. And those two criteria, ANC greater than 500 and platelets greater than 50, were the criteria to start subsequent cycles. And so that's what the benchmark that we used. But again, a well-tolerated regimen leading to deep remissions and translated into significant improvement in overall survival compared to what our historical experience would be. Again, still early. We'd like the data to mature, and we are enrolling more patients to study further.